So in the next 5 minutes, I'll talk about the economic value of liquid biopsy for genomic profiling in advanced non-small cell lung cancer. This was presented at the World Lung Congress. It was a study done in Canada. So this is the background. Personalized medicine has transformed the management of advanced non-small cell lung cancer. We have discovered multiple targets in non-small cell lung cancer, and there's the presence of multiple targeted therapy options for patients who have been discovered to have actionable genomic alterations. So routine testing of actionable alterations can help guide initial therapy, and it is now the standard of care for all patients who present with advanced non-small cell lung cancer. Comprehensive genomic testing with liquid biopsy has been shown to be non-inferior to tissue testing in patients with advanced non-small cell lung cancer and has a potential to identify a larger number of patients who are eligible for targeted therapy. So liquid biopsy is emerging as a complementary approach to tissue biopsy and can be used specifically if there is insufficient tumor tissue, if the tumor is not accessible for biopsy, if the feeling is that the risk of doing a biopsy is too high, and in patients whom we want a quick turnaround time so we can start therapy quickly. But despite its known advantages, liquid biopsy has not so far been routinely incorporated into the diagnosis and management algorithm of advanced non-small cell lung cancer. And why is that? The main reason is cost. So the objective of this study was to assess the cost effectiveness of adding liquid biopsy to standard tumor tissue profiling in selected newly diagnosed advanced non-squamous non-small cell lung cancer in a public healthcare system in Canada. So this was not as liquid biopsy to replace tumor biopsy, but liquid biopsy in addition to a tissue biopsy. So the VALUE clinical trial was a multi-centric prospective clinical trial. It was conducted in 6 Canadian centers. It enrolled treatment-naive patients with stage 4 non-squamous non-small cell lung cancer who were very light or never smokers, so less than 10 pack-year smoking history. So this was somewhat of an enriched population who were more likely to have actionable mutations. Plasma samples were collected from all participants. Cell-free DNA profiling was performed using the Guardant 360 assay, which is an NGS platform that evaluates 74 genes. The standard of care tissue profiling was also conducted as per the routine standard of care, and they collected data on OS, PFS from the clinical trial. The costs were obtained from the Princess Margaret Cancer Centre and from the published literature, and costs and utilities were discounted at a rate of 1.5% per year. So important to remember that Canada is a publicly funded healthcare system, so not exactly applicable in our setting. They did there was this Markov model of decision tree, so we won't go into that, but they divided patients based, so patients either were divided into having a tissue biopsy alone or liquid biopsy in addition to the tissue biopsy. As I mentioned, Canada is a publicly funded healthcare system, and they classified the genomic alterations to either be actionable or non-actionable. So if the patient was found to have an actionable target, if there was an approved or a clinical trial treatment available, then that patient went on targeted therapy. If they had a target which was not actionable or they did not have a target, then they received chemoimmunotherapy. And in this model, this cost model, they only considered first-line therapy. And the cost included the cost of the disease management, treatment-related costs, so the medications cost, the administration cost, overhead costs, cost of terminal care, and the direct testing cost. So I'll skip over this. So this is just to tell you that it was either tissue biopsy or liquid biopsy. And if there was an actionable mutation, they went on to receive targeted therapy. If there was no actionable mutation, they all received chemoimmunotherapy. So these are the baseline characteristics. Median age was 64. 64% were women. Little under half were Caucasian, and a third were Asian. Majority were never smokers or light smokers. 30% had ECOG 0, 48% had ECOG 1, but of note 22% had ECOG 2 and higher. So somewhat of a real world population. 26% had CNS metastases. Majority were adenocarcinoma, 93%. PDL also was a third. So less than 1%, 37%, 1 to 49% was about 30%, and over 50% was 34%. So actionable mutations when they looked only at tumor tissue, they found 53% of patients had actionable mutations. When they added liquid biopsy to the tumor tissue, they found actionable mutations in 68%. So there was an actual value increase of 15% of patients whom they could find an extra actionable mutation. So the median PFS and OS were higher if the patient had an actionable mutation and received targeted therapy. So if the patient received targeted therapy, the median PFS was 11.4 months and the median overall survival was not reached. Whereas if the patient did not have a targetable actionable mutation, the median PFS and OS were 9.8 months and 19.5 months. The bottom part of the slide is was the primary endpoint of this study. So somewhat counterintuitively, they found that if the patient had a liquid biopsy in a tissue, saved 37,000 Canadian dollars per patient. And why did that happen? So that was primarily because in the patients who had the liquid biopsy, in addition to the tumor biopsy, they found at those 15% of patients, they found targetable mutations. And those 15%, those extra patients went on to targeted therapy. So when they had only tissue biopsy, they received more chemoimmunotherapy. And immunotherapy is extremely expensive in the Canadian system as well as in our system. So the limitations were that they did not consider subsequent lines. So this whole model would have collapsed because perhaps patients went on later on to receive chemoimmunotherapy and that was not part of this model. Some patients received best supportive care and all drug treatments and costs were derived from Canadian sources, so may not be generalizable. But the conclusion is somewhat striking and very important for us as well. So the use of liquid biopsy in addition to tissue biopsy resulted in a greater detection of actionable alterations, more patients receiving targeted therapy, and a cost saving of over 37,000 Canadian dollars per patient. The majority of the cost savings resulted from a larger proportion of patients receiving targeted therapy with liquid biopsy and reduced cost associated with inappropriate use of costly chemoimmunotherapy. So these results may vary depending upon the subsequent lines of therapy, but routine use of liquid biopsy in this population should be used as a complementary test to improve patient outcomes and reduce system costs. Thank you.
Thank you very much, madam, for the wonderful insight.